The final speaker of today is Dr. John Rush. He's an age management physician in Washington, D.C., and he's residency trained and board certified by the American Board of Emergency Medicine. Dr. Rush earned his medical degree from Northeastern Ohio University's College of Medicine, and he has an MBA from Pfeiffer University, and he's here to talk about a very modern topic, telemedicine. So welcome to the stage.
So this is my disclosure. I do have a disclosure to make, but I'll try to keep this lecture free of commercial bias. What I hope to convey here today is that telemedicine is the true future of medicine. It will shape the way we treat patients, handle data, and improve outcomes. But first, let's talk about where we came from. It may seem that all of this interest in telemedicine over the last few years can be attributed to telecom advances, but the truth is that telemedicine has been around since the 1960s. NASA built the first telemedicine technology for early spacecraft and spacesuits to monitor astronauts' physiological parameters. In 1964, with a grant from the United States National Institute of Mental Health, the Nebraska Psychiatric Institute began using two-way closed-circuit TV link between the institute and Norfolk State Hospital and 125 miles away for education and for consultations. In 1967, a medical station was established at Boston's Logan Airport that linked it to Mass General. In 1971, not 1967 as this slide said, NASA's ATS-1 satellite was used to verify the reliability of telemedicine between 26 sites in Alaska. In 1972, NASA began a trial with StarPAC, which stood for the Space Technology Applied to Rural Papago Advanced Healthcare. This was a trial to help people living in remote locations with little or no health care, like people living in Arizona's Papago Indian Reservation. It was engineered by NASA and Lockheed Martin at the time, and it used a system of two-way microwave transmissions to link paramedical personnel located here in Tucson as well as in Phoenix. In 1984, the Northwest Telemedicine Project was set up in Australia to provide healthcare to people in 5 remote areas south of the Gulf of Carpentaria. And in 1989, after a massive earthquake in the Soviet Republic of Armenia, the U.S. offered the Soviet Union the use of one-way international telemedicine network for consultations between America at 4 major U.S. centers. Today, patients are more interested in the option of telemedicine visit and more willing to switch physicians to find a practice that offers them. And I don't think you could say that 5 years or 10 years ago, and it is truly, probably you can't say that about us. Age management medicine, we have a much tighter relationship with our patients, and they're not going to switch. This was according to a 2017 survey done by the American Well and the Harris Pool. So what are the benefits of telehealth visits? We all know them. Patients certainly know them. I think sometimes as physicians, we're like taxi cab drivers, and telemedicine is Uber. It's coming. It lowers costs. There's greater patient convenience, improved patient outcomes, and we're going to talk a little bit more about that later in the lecture, and increased patient satisfaction. Again, it's coming. Another finding in that same survey is that 67% of consumers have delayed care due to excessive costs, difficulty in scheduling appointments, and you all know this as well. Even when you're trying to schedule an appointment for your family or your friends with physicians, it takes a while. Improved, a hope that the problem will go away, and they're just too busy. 2/3 of consumers are willing to see a doctor via video. The time it takes to make an appointment, according to a Washington Post report, was an average of 18 days, plus the time it takes to get to the physicians, take off work, etc. According to a Harvard University report, the average time for an in-office visit was over 2 hours, and that included travel, less than 20 minutes seeing the doctor. So listen to some of these statistics. 79% of consumers with ill or aging relatives find video visits very helpful in coordinating their care. 78% of people are willing to have a video visit with a doctor to have a prescription refilled. I took my family over to Europe this summer. My wife and I, we were in London. She needed a prescription, so I happened to have a prescription pad. I wrote it out, went down to the pharmacy, it was a couple blocks away, and they said, oh no, we can't fill this. It has to be a UK doctor. I said, okay, so what are my options? Do I have to take her to an ER? Do I have to go to an urgent care? They said, oh no, you can bring her back, and there's a telemedicine place right here in the pharmacy. So I went and got her, came in, we sat down. It was an immediate uplink. We explained the situation. I told the doctor what I would give her. He said, okay, no problem. I'll write that same prescription. We walked out, and it was just like a little closet area next to the pharmacy. Shut the door, walked out, and I was going to say to the pharmacist that, it went well, and he's transmitting the prescription. She had the bottle right there for us. It was amazing. 60% of people would use a video visit for chronic care management. 50 million people, that's the number of U.S. adults willing to switch their primary care physician to one that offers video visits. The cost of telemedicine visit is now somewhere between a primary care visit and an urgent care visit. In most rural ERs, a psychiatric visit is virtual 100% of the time. And as telemedicine services become more and more prevalent and integrated into the regular operational flows of the U.S. healthcare system, the lines between telemedicine and regular medicine are going to blur to a point that there's no distinction. All new telehealth, telemedicine technology in the future will be just labeled as medicine. And more states are adopting telemedicine resolutions, and as expected, most of those focus on the very costly Medicaid population. These next two slides are going to show how rapidly telemedicine is advancing. In 2014, this chart shows that 33% of practitioners provided or anticipated providing telemedicine services. How many of you do? I'd say that's a third. That's about it. In 2017, almost 75% of practitioners have virtual care initiatives and services in place. That's 100% growth in less than 36 months. As I said before, telemedicine is a rocket that's moving so fast it will cease to exist as we know it and become a part of the norm in healthcare by the end of 2020. But there are some concerns. Crossstate licensure. How many of you are licensed in more than one state? More than 3? More than 5? More than 10? I have 11, so, more than 15? Okay, so in Maryland, they added, I think the state delegates or the state senators, have a pet peeve and they pass these laws, and so we have to take specific CME on death and dying or the opiate crisis or whatever their pet peeve is. In Maryland, I had to get a criminal background check. So I went down, had my fingerprints taken, and they sent it to CGIS, the Criminal Justice Information System. Went back home, filled out my Maryland renewal application, paid my fee, and got my license. 2 days before this conference, I got an email saying, "You've lied to us. You attested that you had your criminal background check done, and we don't have it. So you're going to get a fine, we're going to take away your license, and you have potential other penalties." So I called the place where I had it done, and I said, what's going on? And they said, well, we sent it, let me check. And they said, oh, no, we did send it, but I can see they didn't receive it. I'll send it again. I said, okay, great. He'll call me back in an hour, which he did, and said that CGIS had my information now. I said, well, now do I have to make sure that they send it into the state licensure? He said, yeah, give them a day or two and then call and make sure. So, the onus is completely on you, even if you're doing everything right. There are privacy and confidentiality concerns, medical malpractice and liability concerns, and we'll talk a little bit more about that. credentialing and privileging, telehealth and prescribing, and if you think writing a prescription across state lines is bad now, just wait. Informed consent laws, the FDA and state regulations, the Federal Trade Commission, antitrust, electronic health records, even if yours are okay in your state, you have to make sure that they're okay in the other state, anti-kickback, and Stark issues. So let's talk a little bit about when you're doing telemedicine, medical malpractice, and liability. Most medical malpractice insurance companies have provisions to provide you with that medical malpractice coverage for telehealth, although most companies do retain the right to deny that coverage. Most of the med-mal cases to date with telemedicine stem from radiology. So I'm just imploring you all to make sure you're covered. Don't assume because you're doing the same specialty that you're doing today and you're covered for doing those same services with telehealth. Most carriers want to know the location, the frequency, and the type of services that you're providing. About half of the carriers, I know you're all going to be shocked, do a surcharge or they'll increase your premium if you start doing telehealth. And some carriers only cover telehealth when the provider, you, are licensed in all of the states where you're providing those services. So again, prior to starting a telehealth services, you should obtain written assurance from your medical malpractice carrier that you are covered. And so many of the physicians come up to me and I say, are you sure you're covered for this? If you're new here and you're just going to start bioidentical hormones or you're starting a new type of procedure, make sure you talk to your medical malpractice insurance carrier and don't just talk to some secretary and say, am I covered? And they say yes, and you feel good. You want it in writing. Invariably, they're going to send you an application, fill that out, and do a risk assessment on that and tell you what your new premium is going to be. Anybody think that premium is going to be lower? No, never lower. But it's better than finding out after the fact, after you get a case, and then your medical malpractice insurance carrier denies that because it was outside the scope of your practice or it wasn't on your application. So, where are we going? For aging Americans, getting access to dementia care specialists can be incredibly challenging. Many regions, there aren't any experts around, and even when there are, it's difficult to get elderly, sometimes disoriented patients out of their home and into the doctor's office and that travel. Dementia care, specifically cognitive assessments, are ripe for a telemedicine upgrade. If any patient population could benefit from bringing specialties into the house, it would be America's growing elderly patient population struggling with or concerned about dementia. William Mansbach here on this slide has developed the Enrich program, and it's very simple. The first phase is a cognitive calculator that's easy to take. The second is a more in-depth cognitive screening. And then there's even a third that does cost a little bit more, but there'll be an administrator that will walk the patient and or some of their family members through a comprehensive 30-minute cognitive assessment. Cognitive tests have been available for decades, but this Enrich program really represents a new foray into the consumer-facing tools and products. And again, that's what's driving telemedicine is patient convenience. I also want to mention telepresence robots. The first notable telepresent robot was developed by iRobot for NASA in the early 90s. This was transformed into the VitaBot, which has been used in some Midwestern hospitals for almost a decade. And now there's a range of companies that are entering in this space with promises of beaming the doctor right to your bedside no matter where you are. And Dr. Derek De Silva is working with a company that's doing just that for nursing home visits and for consults. So feel free to talk to him about that. I want to talk about a little bit about Google Glass, the Enterprise Edition. You all remember Google Glass that was announced to the public back in 2012 as a way to create the next generation in personal computing. However, it was really buggy, if you remember. It had a price tag over $1,500, and that was back then. Who knew the new Apple iPhone was going to be over $1,000? And it was basically considered too expensive for widespread adoption, and they discontinued it in 2015. Google Glass Enterprise Edition was just launched 4 months ago in July of this year. So what's different? The optical head-mounted computer with transparent display that brings that information right into your line of sight. It can be clipped onto a pair of glasses. It can incorporate upgraded electronics that make it faster and more reliable. The battery life has been increased and the camera upgraded. And the green light comes on the camera when you're filming, so as opposed to the old one. That was for privacy concerns. Glass EE is only available commercially right now through a dozen partnerships in manufacturing, logistics, and with some healthcare companies. This is a picture of Loyola University Medical Center that's using the Enterprise Edition glass in a pilot program to bring back house calls virtually. And this also does the medical record for you virtually right there as well. Healthcare drones, telemedicine pack. These drones, both octocopters and this fixed wing that you can see on this slide, can carry 20 pounds and fly 40 miles an hour to remote populations. Drones can carry a medical suitcase with variable medical equipment depending on the need. They can also do rapid AED deployment with the touch of an app or a text. An AED could be summoned and on the scene very quickly, within a minute, in a 7.5 square mile radius. Vaccines, medicines, blood products, and other supplies can be delivered by drone as well. Zipline is a company in Rwanda that can deliver 1.5 kilos of payload in 75 kilometers away within 30 minutes. And they can do up to 500 deliveries per day. Shifting age and social demographics are transforming the labor force in the U.S. This, combined with the increasing number of demand for health care, will make our current healthcare delivery system inadequate. So just take a look at some of these numbers. Chronic disease is going to sink our system, and it's going to overwhelm us from a financial point of view. More than half of all Americans manage one or more chronic conditions. Nearly 9 in 10 adults 65 and older have one or more chronic conditions. 86%, or nearly $3 trillion spent annually in healthcare in the U.S. is spent on chronic and mental health conditions. And that's about 20% of our gross domestic product. And so if you put that into perspective, in 1960, the U.S. spent about 6% of our gross domestic product, or $4 billion on healthcare. So that healthcare curve is even outpacing government spending, which is hard to believe. It outpaces inflation, everything. There was only 1 year since 1960 to today, 1 year where healthcare costs in the United States of America actually went down. Anybody know what that is? Say again? No. I'll give you it was before the 90s. It was 1986. It was the advent of the DRG. So it was a payment mechanism that lowered costs. Costs are 2.5 times higher for individuals with one chronic condition and 6 times higher for those with 3 chronic conditions. Nine 9% of Americans managing 5 or more chronic conditions are driving a staggering 35% of all healthcare spending, and that's up from 22% of all healthcare spending in 2006. But telemedicine is going to place population health within reach. The population health management market will swell from $20 billion in 2015 to over $90 billion by 2025. And this growth is being driven in part by remote patient monitoring devices. Telemedicine will upend traditional identification and stratification models. These models have always been and remain a core tenet of disease management. Payers weigh a variety of factors when enrolling patients. But even the most advanced predictive modeling relies on reports of adverse health events and expenditures that occurred in the past. As a result, only a fraction of the population gets tangible support. Up to the minute, biometric data from remote patient monitoring devices wired, routed, and reported directly to health insurance companies will help identify a new pool of patients before they experience a costly emergency. Technology is finally democratizing remote care management, and that's driven by venture capital and mergers and acquisitions. Wearables and other home health care devices are more accessible and more affordable than ever. Emerging technologies expand the reach of population health programs, most notably to underserved patient populations. And Florence Comite, who's right here in front, wave to everybody, Florence, has a wearable on right now and is monitoring her blood sugar and hemoglobin A1C. It's right by her that big butterfly tattoo right there. I won't tell you what's right here, but we'll get to that later. Telemedicine will solve, and here's a tease, I'll go back to that. We talked about in the planning committee for the spring, we're going to have a whole section, a whole lecture on remote patient monitoring devices and how you can use those in your practice to help your patients change behavior daily, so they don't have to wait to come in to see you on a monthly, quarterly basis. Telemedicine will solve the perennial challenge of care coordination. Physicians are unprepared and ill-equipped to manage the complex suite of health and life services for their chronic patients. They know poor care coordination produces negative health outcomes, but feel powerless to intervene, and that's according to a joint study by Johns Hopkins and the Robert Wood Johnson Foundation. I think this was one of the main reasons I got into age management medicine, because I was in the ER all the time seeing the results of poor care coordination. One of my first patients as an age management patient came to me on 4 different blood pressure medicines, 2 of which were 2 different beta blockers. I said, who's giving you all to these? Well, my family doc gave me one. I had some chest pain. I went into the hospital. My cardiologist there put me on one. And then when I went out, I couldn't get in to see that doctor, so I went into another doctor who put me on these other 2. So we called through all of those doctors and got him off of all of those blood pressure, but I don't think he even needed them. To help connect the dots, most large insurers field teams of case managers to help patients navigate the healthcare system. And patients often go weeks or months between clinical appointments, but having real-time biometric data enables connections between the appointments and avoids those negative trends. Telemedicine will improve quality. The annual growth rate of digital healthcare is 48%. The volume of healthcare data will reach 2 trillion gigabytes by 2020. But more data is only beneficial if it's effectively harnessed and meaningfully applied. And that's what Florence is talking about with her wearable, real blood time management. You put the monitor over it, the patient can see it right there as they're eating, what they just ate, and can modify their behavior right then and there. And telemedicine is going to make the healthcare system more nimble. Would anybody in this room describe the United States healthcare system as agile and responsive? I would suggest it's more rigid, arcane, and resistant to change. And that's why I love coming here and listening. I love Caesar's lecture just before me. I loved Anna Kabeka when she was getting the Mintz Award, saying you're constantly in this field banging your head against the norms out there, thinking differently, teaching patients. However, telemedicine is going to help us and help accelerate that change. There's more than 40 health systems that have started their own venture funds. Kaiser Permanente, the Mayo Clinic, the Cleveland Clinic. Geisinger Health System was an earlier adopter of telemedicine and has led the way in a collaborative ICU approach so that ICU physicians can see patients in multiple ICUs. So I hope I've shown you that telemedicine truly is the future of medicine, and I have time for a few questions.
Hey, John. Great talk, and I was just curious, can you comment on, in regards to physicians that, well, for me, like I see a lot of patients from multiple different states, but I'm just licensed in Florida, and you kind of mentioned about you can't write prescriptions over state lines, but I've had no problems with it so far. So is it going to be changing, or?
It is changing already. So if you see the patient, you know,
Yes.
and you've seen them within one year,
Yes.
and then they go out of state, and they, especially if they carry your prescription, they're generally not an issue.
Right.
But you've heard already President Trump's war on opioids. I have had issues where I issued prescriptions in different states, and the pharmacist has called me up and said, "Why are you writing it for this patient? When's the last time you saw this patient?" And I'm just telling you, it's going to get more and more. It's not. I never say you can't do it now. I'm just saying there's going to be more and more restrictions and regulations placed on it. So just get ready.
Okay.
Yeah, I've been writing scripts for 25 years for patients all over the country, and just this past year, one of my patients who's been a patient for about 6 or 7 years in Louisiana, I couldn't write a script for him for testosterone, and they basically won't take scripts from anyone out of state, and I see him twice a year.
Any controlled substance, it's going to get more and more difficult.
Right.
So I think, you know, if you're writing an antibiotic, they're going to let that, you know, go through. But any controlled substance, you're going to have to show that you have a license in that state and or have a physician in that state that will be willing to write that prescription for you.
It's too bad we can't get a general license for all states and have certain kind of...
There is an initiative about that at the federal level, but as you can imagine, the states want to retain those rights.
Right.
And so that's the constant pushback between federal and states.
What I do want to say is there's a lot. I follow the telemedicine because I was able to fly under the radar for 25 years doing telemedicine, and no one ever bothered me. And it's only recently that it's become a big deal. And what I want to warn people about is that there's a lot of articles saying that telemedicine is not a good thing because it actually drives up healthcare costs. Because what happens, and I think this is predominantly in the conventional medicine world, and that's what we have to be aware of, is that it increases the use of office visits, because in a busy medical practice, you get a call, you're on a telemedicine call, you're not sure what to do, and you say to the patient, just come on in, instead of using it as a screening tool or using it to set up a regular appointment to just review labs or do something you don't need to see a patient for. So we here have our own models where we know how to handle it, we're set up, we're structured, but that's not what they do in the regular world. So it's a conundrum, and until it kind of grows up and the model can be sort of structured in a way that works, there's going to be pushback. And the pushback initially came from no payment for that at all. You were banging your head against the wall unless it was a fee for service and you just charged. And so that's going to be what the issue is going to be for the next, I think at least 3 to 5 years, maybe longer.
Absolutely. That was a great comment. And that's what is essential, is getting those protocols down.
Right. Thank you. Excellent talk.
John, what do you think the status of the regulations and allowance for physicians practicing within state lines and prescribing a Schedule III like testosterone to a patient within their state? What is does that end? And I'll preface by saying I know that the rules are different from state to state, but what is your current understanding on the ability to see a patient for the first time, initial patient, as a virtual care visit, assess their information, let's assume that you have adequate information to diagnose, say, a testosterone deficiency and treat and prescribe by telemedicine? Can that be done today?
In your state, so you're within those confines,
Right.
and you have laboratory, and you have seen that patient physically within the past year, yes, you can do that.
So but you're predicating that on the basis that there has to be a physical visit.
Absolutely.
Okay. All right.
That's in most states. So
Right.
I
It's
don't
not
know.
in-
I cannot speak to every specific state, but in most
Right.
states, if you have that doctor-patient relationship, you've seen that patient within the last year, you have a medical record on that patient, you have labs, and that's why I love Caesar. You treat the patient, not the numbers. You know when somebody has metabolic syndrome, you can write that prescription.
Yeah, I mean, that's not true in every state. In my state, you can do that. I think Colorado just loosened their telemedicine laws, and so those restrictions that there's been a dramatic expansion in the telemedicine laws, and really in even just the last 2 years. And we expect by November to be another expansion of those telemedicine laws.
And that's why it's incumbent upon you, if you're doing telemedicine, contact your medical malpractice insurance company, because they have those rules. They know those rules. They can make sure that you are keeping up, that you write down it on the application. Because that's, when a claim comes in, the first thing they do is look at your policy and look at your policy dates. Are you covered within that time frame? Did you pay your premium? Okay, great. All right, so we're going to cover you so far. The next is they look at your application that you filled out with what the claim is. And if nowhere on your application do you say, I'm practicing telehealth, and it's a telehealth claim, they're going to automatically deny it. Now you're fighting on two fronts. You're fighting to get coverage, and you're fighting the medical malpractice insurance case.
The final thing I would say that if you want to practice telemedicine, you need to go lobby your state, legislature. So many laws are being made right there, and if you're not involved in that process, then you're going to be cut out of the process. And you take data just like this, and you deliver it to a state legislator. You ask them, your representative, and you ask them to submit legislation that would improve outreach. Everybody we need to improve outreach, and this is the kind of data that you just simply go and get legislation passed.
That is an awesome comment, and every state legislature has a Doctor of the Day program. You can go down once, whenever they're in session, call up your representative that represents you in your local district, or your state senator, and say, I want to come down and just be the doctor of the day. They sit you in a little room. They'll even introduce you in front of the Senate before the Senate goes into session. You may see, one of the staffers or two that day with a cold or whatever. It's easy work, but you get face time with your representative and with your senators. It's a great way to introduce that and then lobby for the changes that we want.
So my question is, if I see a patient in my office and then they go to another state and I do a Skype call with them, is that telemedicine?
Yes, ma'am.
Okay.
I did OB for 20 years, and this flashbacks me to the external fetal monitoring, continuous monitoring in labor. It sounded really cool, detect every heart rate. And all it did was increase liability, didn't improve patient care, and we still have the same number of babies being born with cerebral palsy to this day. So how do we know this isn't any better than that?
That's a great point, and every wearable that comes out and monitoring everything that, like Florence has on with her hemoglobin A1C and her blood sugar, it's going to be a trial and error, and we're going to have to go through the studies, and they're going to have to be double-blinded, placebo-controlled studies, and we're going to have those evidence-based outcomes. But it's coming, and some are going to be great, and some like that are not.
So in the meantime, somebody's wearing their little monitor, or they got the recording of their little thing of what they showed you, and you weren't quite sure what it was, but you think it's probably this, but now they got a picture of it. Is that really better? I just look at this from a legal point of view, thinking it sounds really scary.
Exactly. You're going to have to wait and see. You're going to have to see what the blood sugar and hemoglobin A1C monitor shows with what they were eating that day. So if they have that food log in their Fitbit, how much You can certainly tell how much people are exercising. Those are all going to be good things, but I'm sure there are going to be things that aren't going to pan out as they...
But is that really a good thing that we have that much data?
We're going to have to wait on the outcomes of that data. What are the results of that data?
It sounds like we're going to become babysitters.
Exactly.
We've got to go home with them now.
I hear you.
Yeah. So.
One more question, and then we're going to go get margarita shots, tequila shots out on the balcony.
As a segue to that question, I know that Florence has a specific type of armband. There's so many out there. I've just recently been introduced to the Hilo that also measures a rhythm strip in real time. It just concerns me that, as the last doctor said, we're going to be getting information that if we don't do the right thing with it, if we can't denote what that means in context, are we opening ourselves up? And which kind of a monitor would you recommend? One that does all those things, or one for diabetics, one for heart patients? How do you know?
It's going to be a trial and error, and all I am trying to establish for you, and maybe the one that Florence is wearing is not going to pan out, but another one is coming. It's going to be on those outcome data and what the research says. Evidence-based medicine.
Any that are better than others?
I don't have that information.
You can't comment. Okay, thank you.
All right, thank you all very much.